Hello again. We are still on section 4, perinatal mood and anxiety disorders, here with the comprehensive mental health course for midwives. And now C, postpartum, is the presentation that we're going to be going over. Postpartum mental health challenges include baby blues, postpartum depression and anxiety, postpartum psychosis, and we'll talk about a reprise, just the screening tools that we had gone over before, not in as much detail, but just a reprise of those tools. So the baby blues. Exploring the differences between baby blues and postpartum depression is extremely important because typical symptoms of baby blues generally pass. There are things that you can do, like calling a mom up and supporting her and bringing a meal, that can help baby blues pass, whereas postpartum depression is going to need a little bit more clinical care and attention. We all know how exciting it is to have a new baby, but that those feelings of confusion and sadness sometimes can be overwhelming, and this is completely normal. Not only are new mom's hormones going all wonky, but her sleep schedule is off, her diet's probably all over the place, and she's focusing on this tiny little amazing creature that she just gave birth to. So this round-the-clock care and these feelings of anxiety, unhappiness, they definitely can be extremely normal. For baby blues, they do appear in the first few days following birth until up to about 2 weeks. These sadness, irritability, fatigue, normal. Sometimes worry, of course, exhaustion. These are all normal. They are often like PMS. About 80 to 85% of moms experience this. This is considered the blues. Symptoms that a mother may feel, as noted previously, the fatigue and the exhaustion. A feeling of malaise as well, which is like an overall blah feeling. Insomnia. Now, this is not being able to sleep even when somebody is watching the baby. So insomnia does not mean that because of focus on getting up for the baby. It's just independent of other needs and activities that are happening during the night. Sadness and crying for no apparent reason. Frequent mood changes or mood swings. Irritability, impatience or restlessness. Feeling of being overwhelmed, a reduced ability to concentrate or focus, and finally increased or decreased appetite. Again, that last one might have a lot to do with the fact that a baby was just born from your body. So, of course, especially if the mother is breastfeeding, there's going to be different nutritional needs. Treatment for baby blues, as we had mentioned several slides ago, is something that can really be done without a professional. This is something that is more encouragement and support, as, again, the majority of women do experience this, and it's completely normal. So in the first week or two, a mother should be sleeping as much as she can and rest when the baby is napping. And yes, that's not always possible, but having somebody there to help, another person to play with the baby so she can rest or watch them at night, little things like that, taking naps, that helps. Diet and nutrition help a lot, especially in the first 2 weeks. So eating foods that are good, feeling better with healthy fuel. So not only specific foods that you like and give you nutrition, but also maybe having a more natural diet. Maybe thinking about having some less glutens and more protein and less processed food and more natural fresh fruits and vegetables. Going for a walk. Now, outside, even if it's cold out, bundle up. You should just breathe some of that fresh air and sunshine, of course, with the vitamin D. So any time that can be spent outside doesn't depend on what time of year it is, but the amount of time that you spend obviously is dictated by the weather. Accepting help from people. Now that's something that sometimes needs a little bit of encouragement because moms do not always want to accept support or handouts, thinking that it may lessen their stance as a mother and their responsibility, but it doesn't. It makes you even stronger of a mother. And then finally, just relaxing. Again, not worrying about chores, focusing on mother's health and baby's health. You know, that baby moon period right after the birth is just mommy baby, and focusing on health and bonding and connection and attachment. And, you know, yeah, it might be a little bit hard to tell a mother to just let the laundry pile up, but during the first few days up until, you know, the first few weeks, really, it makes a significant difference if the mother is just allowed to relax and take care of herself and the baby. Now, with postpartum depression, we're going to see a little bit different of signs and symptoms and different treatment methods. So postpartum depression, well, that moodiness and that sadness from baby blues, if it starts to interfere with the new mother's life, if there is irritability and excessive crying and hopelessness that seems constant, a low self-worth that's repeating, won't go away especially over 2 weeks or so, these symptoms are starting to resemble more of PPD, which is postpartum depression. Again, these symptoms are more severe, and unlike baby blues, postpartum depression also lasts longer than 2 weeks. It can be several months and even up to a year. About 1 in 7 women experience postpartum depression. The majority of these women are able to heal with help. The risk factors for postpartum depression are very similar to those of prenatal depression. So as we discussed in section A of perinatal mood and anxiety disorders, a maternal history of depression or of other mental health disorders, which could be even during a previous pregnancy, or if not during a previous pregnancy, also just during non-pregnant diagnosis of depression or anxiety or any other mental health disorder, definitely increases the risk factor. Mothers who have a family history of depression, so even if they have not experienced themselves, if they have a maternal family history of depression or other mood or anxiety disorders, this also increases the risk of postpartum depression. The family has experienced stressful events during the past year, such as pregnancy complications, illness, job loss, any other types of abusive or violent relationships. As mentioned in the prenatal depression slide, mothers who suffer from domestic violence are much more likely to become depressed than those that are in strong and supportive relationships. And then finally, if the baby has health problems or special needs, it also increases the risk of the mother being diagnosed with postpartum depression. So chronic illness, maybe a developmental problem, not only is caring for the children more difficult, and mothers do dedicate a lot more time and energy and focus on the child, but also because they may have some emotional and psychological trauma, grief, or loss connected to having a special need baby or a baby with health problems when they were hoping that the baby would be healthy. Additional risk factors include a mother having multiples, a mother has problems breastfeeding. This has been linked to higher rates of depression. If a mother's having problems in her relationship, and this is different to the last slide we were talking about violent and abusive relationships, but just having a relationship and then having difficulties, maybe choosing not to be together, a different parenting outlook, maybe somebody is being unfaithful. Again, this is separate from the intimate partner violence, but having problems in a relationship definitely is a risk. Having a weak support system, we did mention this in the last slide a little bit, but the fact that receiving support is a big protective factor, and not having that can actually increase the risk for having postpartum depression. As well can financial problems, low SES, running into problems after pregnancy, or being in a low socioeconomic status previous to pregnancy and then having to struggle after the baby's born for getting things that you would want to get, the individual would want to get for the baby, such as, some nice new clothes or the more expensive diapers. Often formula is an issue, especially for women that don't breastfeed. If they are not able to get WIC, for example, and are having problems struggling to get food or other necessities. And then finally, when a pregnancy is unplanned or unwanted, there is a statistically higher chance of postpartum depression. Luckily, there are many options for treatment for postpartum depression. Support groups really help, especially when moms are able to talk about experiences that they may think affect only them, and they find out some camaraderie. Hey, my baby does that too, or wow, yeah, you know that feeling? I know it as well. Again, it depends on the severity of the depression, but sometimes support groups can be enough to kind of help a mother with that recovery process. Other types of psychotherapy, of course, CBT, we've talked about previously, cognitive behavioral therapy as being a good treatment plan, part of a good treatment plan, as well as interpersonal psychotherapy, IPT, medications, psychopharmacologic treatment, so that's the taking meds, sometimes having meds together with some sort of psychotherapy, such as either like a talking therapy, IPT, CBT has mentioned, or something like a PST, even it was just problem-solving therapy. Again, in together conjunction with medications, because sometimes when individuals are able to talk through with a therapist or a social worker who can conduct this type of therapy, it can help them reduce the risk of continuing with depression past the postpartum period. We also have a combination of brain stimulation therapies that can go ahead and work very well in conjunction with therapy. It's usually suggested that brain stimulation therapies are done as an adjunct to therapy, psychotherapies. So having somebody who is currently working with a therapist or a psychiatrist or both to be involved with brain stimulation therapy and then working it through in the counseling sessions. There are a lot of natural treatments, evidence-based natural treatments that work very well with therapy, counseling, and even psychiatry. Some known for managing stress, such as relaxation, mindfulness, yoga, and meditation, can have a positive effect on reducing the signs and symptoms of postpartum depression. Know that there is a very high probability for recovery from postpartum depression. It's a very good thing to know and to impart on your patients, because sometimes it just seems like things are very down to them. But again, knowing that there's a high probability for recovery, offering support, giving them resources to reach out to, like PSI, or HRSA's got a helpline, 1-800-662-HELP. That definitely helps with further information and support. And in addition to resources, remind the mom that she's not to blame, she's not alone, and help her on that path to healing. Postpartum anxiety. So postpartum anxiety and postpartum depression are not the same, but some estimates show about 25 to 50% of people with anxiety disorders also develop postpartum depression in the 2 months following childbirth. So again, that co-occurring diseases that does tend to happen even more strongly in people who have had previous anxiety disorders or previous mental health disorders in general. The stress during pregnancy actually have a direct effect on the baby. This is something that has been able to be studied, researched, and documented because a quantifiable difference in fetal heart rate and feel behavior that have been directly related to stressful situations, acute changes in a woman's cardiovascular activity as she goes through psychological stress. The general definition of anxiety is uncontrollable and consuming thoughts of intense worry and fear, obsessive concerns, frightening or disturbing thoughts, often accompanied by rapid breathing and rapid heart rate. When this occurs after the baby is born, this is postpartum anxiety, and a lot of this uncontrollable consuming thoughts, the worry and the fear, are directly related to the baby. It's also seen a lot of depressed mood swings, and crying, which is similar to postpartum depression. Difficulty bonding with the baby. Now, some researchers say that not only comes from the problems with the oxytocin release with the mother, but also because the babies, when in the womb, the mother had anxiety during pregnancy. Often the babies are born a little bit more hyperactive, a little bit more hypersensitive, not able to console as easily, and sometimes that also causes difficulty bonding. Withdrawing from friends and family, loss of appetite, eating too much, too little, inability to sleep. Again, you'll see that these are very similar to some of the depression signs and symptoms, especially the fatigue, loss of energy, reduced interest in activities that used to be enjoyable. And yes, some of them will overlap, but having that obsessive thoughts and concerns, the fears, the worries, that rapid breathing, that is more associated with the anxiety. In continuing the signs and symptoms, there's often intense irritability, anger. There's fear that you're not a good mother. It sometimes becomes a vicious cycle that, the postpartum anxiety is full of fear of not being good enough. But then when the individual realizes that because of the anxiety, they're taking time away from the baby and not being a good mother, that makes this worse. So now they really are fearful of having a tangible reason of not being a good mother. And again, that's that anxiety vicious cycle. They may feel hopelessness, feelings of worthlessness, shame, guilt, inadequacy, again, very similar to postpartum depression, a diminished ability to think clearly or concentrate or make decisions. Sometimes people seem like they're in a fog, and, yes, again, this is more common with depression, but it does happen with anxiety, especially if you can't focus. Restlessness, sometimes a severe anxiety attack or a panic attack, and then these last two, something that everybody should be warned about, any thoughts of harming themselves or the baby, or thoughts of death or suicide. Again, that does occur, but if that ever happens, not only, obviously is required to report, but see if you can find somebody that can help the individual, a licensed mental health provider who's actually worked with postpartum anxiety before and postpartum depression before, somebody who has training. PSI gives training in perinatal mood and anxiety disorders, because again, when somebody is thinking of death and suicide, we'll talk about postpartum psychosis. These here are not all symptoms of postpartum psychosis, but some of them can be beginning signs that significantly increase in intensity. And so again, that is something to look out for and continue screening for. Asking the questions: have you been hopeless? Have you felt a depressed mood, sadness, sleeping too much or too little, as it says here. And again, knowing that if there's some depressive symptoms, typically it's good to reach out for support, or likely depressed, reach out for support. But those last two bullets there, that's definitely something where you need to get another healthcare provider, mental health provider involved. Now, similar to postpartum depression, treatment is widely available. We did talk about CBT and IPT and just psychotherapy itself, of the talking with a counselor, therapist, social worker, other mental health provider. Again, noticing the relaxation making a significant difference, using relaxation meditations techniques, mindfulness, yoga, and then some. Aromatherapy is also helpful. It's mentioned here and not in the pregnancy one, because even though there are some scents that you can take through a diffuser and do not have cannot have a negative chemical effect, it's still good to be careful during pregnancy, because some can, especially if you put oils on your skin. But mentioned here, having these calming, soothing oils, it's definitely something that has been shown to help reduce anxiety and stress. If you're breastfeeding, don't not put it on your skin. Pharmacotherapy, so medications that we've talked about, SSRIs and SNRIs, so selective serotonin and noradrenaline reuptake inhibitors. Yes, they can definitely improve your mood, but when a postpartum issue is affecting the mother, it's going to affect the baby as well, just like during a pregnancy mental health issue. So sometimes balancing out types of medication that are being taken and augmenting them with other types of treatment can actually help with the entire process. The increased level of mood stabilizing brain chemicals is necessary. Benzodiazepines work to reduce anxiety, but again, depending on the severity and whether the mother is breastfeeding or not, the prescribing practitioner will determine what needs to be given to the mother and really the best course of treatment at that point. Postpartum psychosis. So very, very rarely occurs, but it is also extreme. So PPD, about 1 to 2 out of every 10, and PPP, which is postpartum psychosis, is 1 to 2 out of every 1,000. So, again, it is rare, but it is done. As we discussed in the general mental health slides, psychosis is a break from reality, that disconnection there. Mother may have hallucinations or delusions. Some of the main symptoms are paranoia, irrational judgment, and losing touch with reality, disconnecting from reality. So they may say things like, I hear people talking to me, or I've been getting extremely anxious because X, Y, and Z. There are people, there are individuals talking in my house. I see special meanings in advertisements, or something on TV is reaching, somebody's trying to get through to me. When they look at a person, sometimes they may see something that does not look like a person. Their face may change. If they look in the mirror, they may see their face changing too. And other things such as not being in control of your thoughts, being distracted or distant because you're listening, not, because you're zoning off, but because there's auditory or a visual hallucination, and seeing things that people don't necessarily see. Again, all part of losing touch with reality. Now, not only the signs that you can see, but these symptoms that the individual may feel: obsessive thoughts about the baby, strange behaviors and strange beliefs. It tends to be a lot of nightmares, paranoia, being suspicious, feeling suspicious of even people that the individual has previously trusted, like a spouse or a parent. Again, the mood swings, excessive energy and agitation, and then finally attempts to harm self and baby. As we said on the other bullet, we know that this is a time to reach out for help. The clinical features of postpartum psychosis include disorganization, confusion, Derealization and depersonalization, and these are two symptoms that we've talked about when we were discussing dissociative disorder. So the derealization feels like you're in a dream, feels like nothing is real, you're not in real reality, you're removed from it. Depersonalization, you don't recognize yourself when you look in the mirror, you feel like you are somebody else is in your skin, that you're in somebody else's skin. This is described many different ways, but essentially you're not you. Insomnia, can't sleep, irritability, abnormal thought content, again, which is similar to the symptoms that the individual is feeling, those delusions and the hallucinations, as well as abnormal mood, which could be mania, agitation, depression, or these mixed. So as I mentioned before, postpartum psychosis sometimes starts with the signs and symptoms of other mental health disorders, such as depression and anxiety, where there's problems sleeping, and then, the individual seems just irritable and off and just does not feel like things are starting to click, and then it starts to ramp up and get more intense. Often you can see a ramp up, other times it just jumps right up away to intense feelings or hallucinations or delusional beliefs. The highest risk of a patient with postpartum psychosis, suicide and infanticide, the killing yourself and or your baby. These are two high risks and ones that need to be taken seriously. All of these need to be taken seriously. And if anybody says anything about death or killing themselves or killing their baby, again, assuming that it's just, baby blues, or it's hard for everyone, postpartum psychosis is very rare, I doubt that that's really what's going on. Unfortunately, something like that, especially when you're not validating their feelings, can lead to something serious. So encourage, listen, and follow through. Be there. Now, when you're making a referral, keep in mind that postpartum psychosis should only be treated by a licensed mental health professional. There are multiple antipsychotics and mood stabilizers that can be used in conjunction with therapy. Risperidone, Zyprexa, Geodone, and Abilify. Abilify and Risperidone being the two that are prescribed more commonly. These two are also prescribed in the pediatric population, but these antipsychotics can help. Of course, with postpartum psychosis, there are other levels of treatment, support, and care that all need to be taken into consideration. A mood stabilizer may be needed, such as like a lithium or Lamictal or a Depakote, which Depakote is actually an anticonvulsion medication, so it does help with stabilizing moods, but there also needs to be a therapy, a psychiatry combination. So that psychology, psychiatry support back and forth to, let's talk, let's work through maybe like a DBT or a CBT in association with the mood stabler, the antipsychotic. That relationship, that psychology, psychiatry relationship just is very important, needs to be very clear to the patient, as well as the psychoeducation. That's something that, especially when the individual is, in a mind frame that they can take in information, talking to them a little bit about what they're experiencing can significantly help. In the next 2 slides, we go over just a reprise of the screening tools, because we have mentioned these tools previously. Now, these are screening, again, not a diagnosis, but they will be able to give you a good idea of whether your patient does need a follow-up with a mental health referral. And keep in mind that when you're making your referral, that you look for an agency or a practice that has a good understanding of the perinatal period. You don't want to just send your patient is somebody for depression that works with depressed mothers, if they don't have specific training in perinatal mood and anxiety disorders. Same thing with anxiety. You should also try to see before you give a referral, what kinds of insurance the mother has, which you may know already from working with her, and see if they either take her insurance or have a sliding scale. The availability is important. Just kind of have a good feel for that. And also keep in mind that mothers who are depressed, or have another mental health disorder, they may actually need some help following through on a referral. You can ask them, you can explain the process to them, maybe walk them through it, tell them what's going to happen. Sometimes explaining the types of things they should be prepared with or prepared to hear may help. Also, keep in mind that even though you're not the one prescribing the psychiatric medication in that case, you want to make sure that you do sign a release. So as long as you're continuing to see the patient, that you and the mental health provider can be on the same page when it comes to therapy and medication and what have you. So again, these are the depression tools. Center for Epidemiologic Study Depression Scale, which is good with postpartum. We've got Edinburgh, which was initially validated for postpartum, and it is now validated for pregnancy as well. But again, since we're talking about postpartum here, it's still a good one to use. The PHQ-9, there's a PHQ-7 as well, last question. So, depending on the agitation level of your patient, if they've got problems concentrating, it's good to give them a shorter one. You can always walk them through it and talk them through it as well. And then plus the Beck Depression Inventory 2 it's a self-report inventory. Again, some of these are good as a screening if you already feel as though you would like to ask your patient to extrapolate on some of the symptoms that she's been talking about. But as a standard, they should be given to all women in prenatal and postpartum visits. And anxiety tools, so we got the GAD-7, which is generalized anxiety disorder. Again, brief diagnostic tool, and the perinatal anxiety screening scale, PASS. And so it's a little bit more in depth. This one's 31 questions, but again, it does cover the broad range of anxiety symptoms. And here's some references, and thank you for your participation in this section.